This episode was recorded prior to January 20th.
Hello, and welcome to ACR Journals on Air podcast. I am your host, Vicky Shamagam. It's a syndrome that strikes fear into the heart of every graduating rheumatologist. A patient presenting acutely unwell with fever. Could it be macrophage activation syndrome? Well, the manuscript we will discuss today is called Macrophage Activation Syndrome. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures are in our show notes from today. Dr. Peter Nigrovich, who is joining us today, is a macrophage activation syndrome expert. He is both a pediatric and adult boarded rheumatologist, and he is the chief of the Division of Immunology and an attending physician in the rheumatology program at Boston Children's Hospital. He is also the Prince Turki bin Abdul Aziz Al Saud Professor of Pediatrics at Harvard Medical School. He directs the Brigham Center for Adults with Pediatric Rheumatic Illness, fondly known as CAPRI, and he specializes in the long-term care of individuals with childhood-onset rheumatic diseases as they grow through their lifespans. Academically, he directs a basic and translational research group focused on mechanisms of inflammation in arthritis and systemic lupus erythematosus. Welcome to the show, Peter.
Thank you very much. Delighted to be with you. Thanks for the invitation.
So, Peter, I wanted to start with some history. Macrophage activation syndrome has been something I have certainly feared since medical school, but it's only really had its name since 1993. Where does the name come from?
So as far as I can tell, the name comes from was coined in a paper in 1993 where the senior author was Anne-Marie Prieur, who's sort of a great in pediatric rheumatology. And in this paper, she and her co-authors described 4 patients with rheumatic diseases who had a hyperinflammatory state where when they did the evaluation, they uncovered evidence of activated macrophages. They saw macrophages doing hemophagocytosis in the bone marrow. And they saw evidence of circulating cytokines that were macrophage-derived potentially. So they called it macrophage activation syndrome based on those observations. And the term is stuck.
Names for what I think is the same syndrome. So some people call it cytokine storm, hemophagocytic lymphohistiocytosis. Some people use the name Still's disease. Are these all just different names for the same thing, or is there more nuance to some of these names?
Yeah, the terminology is confusing, and that's partly because it's really not consistently used. Still's disease, as I use it, the overall disease spectrum that includes systemic JA and adult onset Still's disease, which I think are clinically and pathophysiologically a spectrum rather than anything divided by adult onset or pediatric onset. And this use of the term Still's disease has recently been endorsed by a EULAR Press consensus group led by Dr. Bruno Protel and Dr. Fabrizio De Benedetti. And that's published recently in ARD, which proposes the use of that term. So Still's disease is the overall background disease in which MAS can happen. In rheumatology, Still's is one place we see it. It's not the only place. We also see it in lupus, Kawasaki disease, and other conditions. HLH, or hemophagocytic lymphohistiocytosis, is an overarching term for disease in which uncontrolled immune activation leads to systemic toxicity. So sometimes the disease happens because of monogenic defects, so inborn errors of immunity. These are called primary HLH. And sometimes they come as a complication of other diseases in which it's called secondary HLH. And in its most restrictive use, the term MAS is secondary HLH related to a rheumatic disease. However, that use is I think, observed inconsistently. And more generally, we as rheumatologists use the term MAS refer to the general syndrome of this hyperinflammation, even if we don't know its cause. And it might end up being sepsis or tumor or something else. The term cytokine storm, I think, is a colorful way of describing what we think is going on in MAS, though like the term macrophage activation syndrome, it embeds a mechanistic hypothesis about what's important. So I think we should be a little careful with the term. In the review, I use the term cytokine storm less because I don't find it so helpful. Some cytokines are actually good. So IL-10 is a counter-regulatory cytokine. And I'd rather think about what's going on pathophysiologically rather than using that term, though I think it's a fine descriptive term.
So refresh our memories. If we're standing at the bedside, seeing a patient, and the thought of macrophage activation syndrome crosses our minds, what labs should we be ordering as soon as we think of this syndrome?
So these patients are almost always very systemically inflamed. So clinically, they have fever, often lymphadenopathy. Often they look ill. Sometimes they may have rash. And corresponding to that inflammation, they have elevated inflammatory markers, in particular C-reactive protein, which, as you know, is a marker of high IL-6 and other cytokines. SED rate is also usually high, but SED rate's got a little trick to it in MAS, which is that the SED rate rises because IL-6 drives fibrinogen production by the liver. And fibrinogen may be consumed in MAS, so as a part of the DIC syndrome. So the SED rate may actually paradoxically fall. And that's actually sometimes clinically useful. So you have a general inflamed patient, but what's more specific for MAS is ferritin is probably the best marker. So this is, as you know, an iron-binding protein. We think it's released by activated macrophages. That's not entirely sure. But it's elevated in inflammation in many conditions, but it goes up disproportionately in MAS, and it's a really good marker. LFTs, AST and ALT go up. CBC is very useful. So there are often cytopenias of different kinds. And in particular, platelets may fall, and that's a marker of DIC. Other DIC markers are D-dimer and fibrinogen level itself. And then there are more specialized tests. And these have really come into their own, I think, over the last few years. Interleukin 18 is an interferon gamma inducing cytokine that is very, very high and really specifically high in the Still's disease spectrum. Activated T cells, which happen a lot in MAS, release there's a surface IL-2 receptor, and this is released as the soluble IL-2 receptor or soluble CD25. And then a really interesting marker, a powerful marker, is CXCL9. That's a chemokine that's triggered by interferon gamma in a very specific way. And since interferon gamma itself is hard to measure, CXCL9 is a fantastic proxy marker to see how much activity is going on with interferon gamma. Triglycerides have historically been used, and they are elevated, but they have to be done fasting. They're affected by other labs. And I think a lot of MAS experts don't use it as much, though it is on the list still.
So I wondered if you could jump us forward to a couple of the figures. In figure 1, you have a great pie chart that looks at the relative causes of MAS and compares children with adults. And what's very striking is that these two charts are quite different. I wondered if you could talk us through it. What are the different etiologies for MAS in children versus in adults? And maybe just give us a little bit of background as to what we should be thinking of when we're seeing patients with this syndrome.
Yeah, I think when we see a patient with MAS, the first question is, why is it happening? And the main point of this figure is to show that there are multiple possible causes, both in kids and adults, and there's some difference depending on the age of the patient. These data are plotted actually from a lot of work done by a group from the ACR and EULAR that wrote a consensus statement about MAS diagnosis that was published in A&R and ARD in 2023. The first author is Dr. Bita Shakouri, and the group was was led by Scott Canna, Rafael Gobakmansky, Fabrizio De Benedetti, and Rebecca Marsh, also all great experts in this area. But what's plotted here specifically is the results of a comprehensive lit search that they did of published series containing more than 30 patients in which the causes of each case were delineated. So that's not anywhere near a comprehensive view of all MAS in the world. It's just what they could look at in their particular literature research. So I wouldn't take the data too literally and say a percentage is this, a percentage is that. But instead, I would use it as a broad guide of what kind of things happen and relatively how common are they. So if you look, for example, at pediatrics, you'll see that the major cause is actually infectious. There's also idiopathic disease, but then this inborn errors of immunity, these monogenic diseases are fairly common. Whereas malignancy happens, but it is less common. But then if you look at adults, the dominant fraction of MAS in the adult world is malignancy. and infection is next. And rheumatic is important, but it's not as important, and inborn errors become much less common. So I think that's the main point here is when you're seeing these patients, think about other things. And in particular, in adults, don't forget that lymphoma and leukemia, these malignancies, are a dominant cause.
Really good tip. Let's talk a little bit about the mechanisms. And I should also mention the visual for this part of our discussion is figure 2 in the manuscript, which has this beautiful image of the cells involved in driving and perpetuating MAS. But first, I was wondering, Peter, can you help us understand, is the macrophage actually a driver of this process or just the innocent bystander?
Yeah, we call it MAS, and I think fortunately it's not too far off the mark. I think macrophages really are very important as a driver of this disease. And as I mentioned, ferritin, I think, probably reflects that. Although you don't, as the macrophages eat erythrocytes and have to do something with all the iron that they ingested. Though frankly, that's just a guess. There's not a lot of direct proof of that. But what I think this figure shows is that it takes two to tango in most cases of MAS. And the two are macrophages, here termed antigen-presenting cells, because it can be other cells as well, but also CD8 T cells and other cytotoxic T cells. And the reason is that usually these two work together in a way that limits excess immunity, because there's an important negative feedback loop. So when an antigen-presenting cell presents antigen to a T cell, that T cell can feed back on the macrophage by killing it, frankly, but in order to shut down the excess signal. And that killing is done via a molecule called perforin, which is in a granule that's then brought to the surface. And so the macrophage activates the T cell shuts the macrophage down. But the T cell also can do something else, which is make interferon gamma, which actually activates the macrophage. So if the cytotoxicity signal is impaired, then what you get is a vicious cycle in which the macrophages activate the T cells make interferon gamma and other factors that then further activate the macrophages. And so this vicious cycle happens, for example, in primary HLH, where perforin is missing or the compounds that bring perforin to the surface are missing. And so that the immune system can't shut itself down. So I think that's what's going on here. And the cytokines made both by the T cells and by the macrophages are what make up at least part of this storm. What I do want to point out is that this is probably happening in a lot of cases. Ed Behrens had a very interesting model of MAS induced in a mouse by recurrent injection of toll-like receptor ligands. And what he showed in that model was that you didn't really need the CD8 T cells. Just so if you really hit the macrophages hard, you could get enough cytokines out to make it look like MAS. So there are probably some cases in humans where the arms of the vicious cycle are just a little different.
Yeah, I think it's really fascinating. And these kind of single gene or inborn errors of metabolism where you find unique defects that help you explain some of the very young children who develop MAS, it can be very helpful in understanding pathways. And I think perforin is one of those. Can you tell us a bit more about how it was kind of discovered that this was important and what that tells you more broadly about the mechanisms driving MAS?
Yeah, perforin is made by cells that kill other cells. CD8 T cells, killer cells are key there, but NK cells and other cytotoxic lymphocytes can also make it. And if it's missing, or if there's defects in other proteins involved in bringing granules containing perforin to the surface or allowing the granules to fuse with the surface, then you have a defect in cell-cell killing. And that is thought to be the main cause of primary HLH. And in a secondary HLH, you can get either cytokine-induced defects in that same cell-cell killing. For example, NK cells exposed to cytokines make less perforin or less able to kill. So I think it's important probably primarily in the primary HLH, but also to some extent in secondary HLH.
Okay, so, we can't talk about cytokine storm and macrophage activation syndrome without talking about cytokines. And to the untrained eye, this does look like an unpredictable weather pattern, but just like the weather, even cytokines have patterns. And you perhaps are the expert cytokine meteorologist who can help us understand those patterns. So tell us what is going on when the cytokine storm starts.
Yeah, I think there are lots of wonderful experts of MAS around the world who have taught us about these mechanisms. I think that the vicious cycle gives you two arms. One is the APC stimulating the lymphocytes, and the other is the reverse. And each of these make cytokines. But if you had to remember one cytokine in MAS, it'd probably be interferon gamma. This is made principally by the lymphocytes, including a subpopulation of these cells you see in the peripheral blood, which Puyi is termed cycling T cells. They've been described by other groups, both in the US and in Italy. And they're a population of lymphocytes, mostly CD8 cells, some CD4 cells, some NK cells, that bear markers of replicating and also of making interferon gamma in the blood. And so that is a really important cytokine, as we'll talk about, I think, later on when we get to therapy. But there are other cytokines of interest. IL-1, IL-6 are ones made by antigen-presenting cells or macrophages that stimulate themselves as well as T cells. IL-18 is made probably by macrophages and other cells producing that promotes interferon gamma production. Type 1 interferons and IL-15 are also important. So this, I think, hadn't been broadly appreciated, but several recent reports by Puyi and Grant Schulert and others showed in some nice JCI papers last year that there's type 1 interferon signal as well as type 2 interferon signals, and that Puyi showed that the combination of type 1 interferons and IL-15 drives the production of these cycling T cells or cycling lymphocytes, at least in vitro. Then IL-2 is an important cytokine. So IL-2 is a survival cytokine for T cells. It's made by activated T cells and allows them to keep reproducing. So that's probably important. Ed Behrens has nice data on IL-33 that showed that it's relevant in a mouse model. It's a kind of an alarmin kind of cytokine. And if you look very carefully in MAS patients, you can see that IL-33 is actually very specifically elevated compared to other sources of fever. Again, work by Puyi. And then intracellularly, these cytokines seem to integrate on a pathway called the mTOR pathway. And the mTOR pathway is a central metabolic integrator within the cell. And in work that Puyi started when he was in my lab and then continued on his own, showed that this pathway, when activated, can account for the development of hemophagocytes and disease in mouse models with some correlated in humans. And it's actually mTOR antagonists, so sirolimus has been used in systemic JA itself. There's a case report by Dr. Arturo Berzitsky from Chile. And Dr. Seza Ozan from Turkey has published the first case report of its treatment using sirolimus to treat a macrophage activation syndrome. So I think that's an important pathway too.
Yeah, it's a really complex process. I'm going to take you back to that question of, when we're standing at the bedside seeing these patients, there are a few of these more research-driven cytokine measurements that can be useful clinically. Can you tell us, as someone who is a clinician seeing these patients, if someone works outside of a tertiary center and wants to order these labs, how can they do it? And then second part to that question is, how quickly do the results come back? How do you put them into practice when you're making clinical decisions?
Yeah, it's a very important question. I mean, I think that a lot of the work in MAS care can be done with labs that are available pretty much everywhere. So ferritin, CBC, LFTs, CRP, D-dimer, those are very useful tests to tell you what's going on. IL-18 is a send-out, at least at many institutions. So many institutions send it, for example, to Cincinnati Children's Hospital. They have a wonderful central diagnostic lab. But I think it's now becoming more broadly available. I believe in 2025, we'll have it here on site for a quick turnaround as well. And here at Boston Children's, it's very useful diagnostically because it really tells you that something's going on that's in the Still's disease spectrum. Although it doesn't change very dynamically, it changes slowly. CXCL9 is probably the other one that's of really critical value to tell you that there's an interferon gamma signal. CXCL9 levels are pretty normal, even in active Still's disease, but they go up once you start to go on this vicious cycle. And that's a very useful marker and also helps you monitor therapy with interferon gamma blockers if you go that way. And soluble IL-2 receptor is also very useful in monitoring T cell activation. So these are labs we try to monitor twice a week when we can in our inpatients. And those can either be send-outs or they can be done locally.
Yeah, so always pays to know a pediatric rheumatologist in my book. So ultimate question, and this has come up many times to me on rounds, and so I'm sure it's come up to others. If the clinical picture is clear, do people really need to ask for a bone marrow biopsy to make a diagnosis of MAS?
No. And the reason is that it's neither sensitive nor specific. So you can have hemophagocytosis in patients with Still's disease who are not in MAS, and you can have patients who are in MAS that you don't find it on a biopsy. And probably if you biopsied all the bone marrow, you'd find it, but if you do just a core biopsy, you may not see it. It is in the HLH 2004 diagnostic criteria as one of the possible pieces of evidence for the HLH spectrum. And in that context, it can be useful. But for us, we do bone marrow biopsies when we want to rule out other things, particularly leukemia. So if you don't need it for diagnosis.
Great. So let's talk a little bit about treatment now, because obviously these people are very sick and sometimes we do have to treat first, ask questions later. So as you show in figure 3, there are now multiple treatment options that can be used at various points in this cycle of cytokine storm. And could you just kind of walk us through them? And I guess I'm going to ask you to start with the rheumatologist's favorite drug, which is, of course, steroids. How do you like to dose them for MAS? And can you tell us about the pros and cons of dexamethasone versus methylprednisolone for MAS?
Yeah, great question. So steroids are a blanket that shuts everything down in the immune system. They block NF-kappa B and other pathways. And I think that they are the bedrock of care of MAS. So in very few cases can you treat MAS without using steroids, and usually at pretty high doses. So our practice is typically to pulse. That means 30 milligrams per kilogram up to a gram of Ciomedrol IV, usually times 3 days. That's usually our start. And then you can do oral tapered, usually starting at 1 per kilo or something in that range, going down. But sometimes you may need longer or higher doses. But steroids are, as you know, are toxic. They don't fix the underlying biology particularly well. And so we like to go to cytokine blockade next. Our preference here is to use IL-1 blockade, short-acting anakinra, which is, as you know, it blocks the IL-1 receptor, so blocks both IL-1 alpha and IL-1 beta, although we think IL-1 beta is probably where the real money is in this syndrome. But the advantage of anakinra is that it's very short-acting, so it's short-lived. It's got a half-life of 4 to 6 hours. And it also has an extremely high therapeutic index. So if we think about the dosing of anakinra in patients with Still's disease, for example, we often talk about 1 shot or 2 shots a day. So that's 100 milligrams once or twice a day. But when anakinra was first studied in sepsis trials, it was used in doses of 2 milligrams per kilogram per hour. So really, much higher doses in patients who are overtly septic. And that was, it increased, it improved mortality a little bit. So we should feel confident about using anakinra in very high doses when necessary.
What about the longer acting IL-1 blockers?
Yeah, good question. So canakinumab is a longer acting one. It's the monthly dosing, much more favored for outpatient care. I think for inpatient use, it's much harder you don't have much dose range. It's probably harder to get as an inpatient therapy. You can't titrate it up and down to see what's going on. So although there are case reports of patients treated with canakinumab for MAS, we don't really tend to use it very much for that purpose. There's a third IL-1 blocker called rilonacept, which is an IL-1 trap. That is probably pound for pound less potent than the other two because it binds not just IL-1 alpha and beta, but also the IL-1 receptor antagonist, the blocker of both those cytokines. And so it doesn't really have, to my mind, any utility in this context.
Yeah, good explanation. So what about the JAK inhibitors? There are a few of those. What does the data show for JAK inhibition?
So I think if you had to say what does the data show in treatment of MAS, we would have a very short conversation. There are studies and they are useful. So the best probably is a paper out of China from Zhang in Blood in 2022. And they studied 52 children with HLH, mostly secondary, probably mostly from EBV. And they used ruxolitinib, which is a JAK1/2 inhibitor. And they had a response rate of 70% and remission rate of about 42%. And a lot of those patients needed something else ultimately, but it showed that the drugs work. There are other smaller case series in adults as well as children showing efficacy. And there's good mouse data that this works too. So there's nice sort of evidence around the block. And I think it makes sense that they do. So many cytokines that we implicate in MAS work via the JAK pathway. So interferon gamma and IL-6 work via JAK1 and 2. Interferon alpha works via JAK1 and TYK2. And IL-2 and IL-15 work through JAK1 and JAK3. So I think that it makes sense that these drugs work and they do clinically. There probably isn't a huge difference between them because JAK1 is in all of those pathways that I just mentioned, and ruxolitinib and tofacitinib, baricitinib, and upadacitinib, which are the ones available in the US, all antagonize JAK1. But ruxolitinib is the one that has the most experience, since that's what we go to first.
And what about the calcineurin inhibitors? Have those fallen out of vogue, or are they still being used?
Yeah, I think vogue is just the right term. There's a long track record of use of cyclosporin and tacrolimus in these drugs. They're in MAS. I think that as the appreciation of the importance of interferon gamma has grown, these drugs, which we think probably work on the T cell angle, so they stop these cycling T cells, that's just a guess that hasn't been shown, but that they block the T cell activation, that's gotten a little less fashionable, I think. The other reason we don't use them as much, or we now prefer the JAK inhibitors, is speed of onset. Again, that's just very impressionistic. It's not based on data. And then sometimes hypertension and CNS implications of hypertension, in particular, a syndrome called PRES, posterior reversible encephalopathy syndrome, has been associated maybe with calcineurin inhibitor use, but really, again, very associative. I think they're a completely appropriate choice for MAS. They'd fallen a little bit out of favor.
Yeah. However, there is something sort of newer that's come into fashion, which is a monoclonal antibody that neutralizes interferon gamma. Its name is emapalumab, I think.
Yes, exactly right. Yes.
There were some clinical trials for this agent, correct? Can you share what those showed?
If you looked at the clinical data, you might say that this is the drug with perhaps the best evidence base. There's a 2020 New England Journal paper in 36 patients with primary HLH, most of whom had really failed other therapies, including etoposide, which is a big gun in this condition. And they had a 65% response rate. So that got this drug, which is an anti-interferon gamma antibody, got the drug FDA approval for use in primary HLH, typically as a bridge to transplantation. In follow-up work published in 2023 by Fabrizio De Benedetti and his colleagues, they found that they tested emapalumab in Still's disease, MAS refractory to steroids. Most of those patients had been either on cyclosporin or anakinra, and they got remission in 13 out of 14 patients by week 8. Of course, other steroids went down. They had good responses. And a follow-up real-world paper by Ed Barron's group in 2024, published in A&R, showed comparable results, although they did have one patient who died of viremia. Viremia is considered not drug-associated by the investigators, but that's a little hard to swallow in a drug that's involved in viral defense.
Right.
I think emapalumab is a great drug. We don't really know where to use it in the algorithm. I think arguably it could be certainly co-equal to a JAK inhibitor or calcineurin, potentially. I think cost is an issue. Here at Boston Children's, the list price for emapalumab for a 20-kilo kid for a month-long course at usual doses, and we often go up, it's about $1.5 million. Hard to know what to do with a number like that. We're responsible for taking the best care of our patients. Yet that's an eye-opening number. And you can see where that's, even if it's available for many of us, it won't be available for all around the world like this.
Yeah. Wow. Astonishing number. So there are, however, some other old-fashioned drugs that I'm assuming might be a little bit cheaper. And one in particular is the chemotherapy agents that you just mentioned. So etoposide, is there a place for it for MAS?
I think so. I think the hematologists are much more comfortable with these drugs than we are as rheumatologists. And that's in part, I think, that they deal with life-threatening disease. And so life-threatening side effects are less concerning, I think. There's the main issue with etoposide, which is that it does have a secondary malignancy rate. It's probably small. I think the numbers I saw were something like 0.5% at 5 years. But you're dealing with a 3-year-old kid, they have a lot of 5-year intervals ahead of them. That is a concern for us. So we tend to put it really to the end of the line. It kills cycling T cells, cycling lymphocytes, which makes it an appealing option. Cyclophosphamide does the same. But we reserve it typically for when other agents have failed, including emapalumab.
Yeah, definitely. And then can you bring us up to speed on data for some of our more traditional agents? So I'm thinking B-cell blockade, IVIG, IL-6 inhibition.
Yeah. So B cells are not thought to be a big player in this in general. The the place that B cell depletion can be useful is in patients with EBV, where EBV is the driver and B cells are the reservoir. So if you give rituximab to a patient who's got a high EBV viremia, the viremia usually goes way down, and that reduced antigen loads can help reduce the pressure to driving this vicious cycle. So the data for that are basically case series and anecdote, not any trials, but it is something to reserve for that context. Otherwise, I wouldn't use a B cell drug. IVIG is supported by small, uncontrolled trials. Most MAS experts don't think it does much. It is safe, so you can throw it on top of everything. And it's maybe gives you a little immune protection. Volume may be a problem. I would say you could throw it in as an adjuvant to other things, but I wouldn't count on it for primary treatment. We don't really have a good sense of how it works, although, of course, that's true with IVIG generally. And then IL-6, this is a tricky one, I think. So the general consensus among most MAS experts is that we don't go to IL-6 blockade for MAS. And yet there are case series of patients treated who seem to respond. So how do we put those pieces? And we have, IL-6 is on our chart here, what the things that macrophages do to stimulate themselves. So I think the reason that it's a little out of favor is that we know that systemic HA patients who have very high IL-6 levels actually tend to get arthritis and not MAS. We know that patients on tocilizumab seem to have an MAS incidence that's similar to that of patients not on tocilizumab. Of course, you could say something similar about canakinumab, the IL-1 blocker. I don't think it's a terribly unreasonable drug to use. We don't use it because there are other options. And from my point of view, more because of concern over infection. So very often in MAS care, you have some diagnostic doubt. How much is infection contributing? How much is co-infection happening? How much is infection the primary process? And I think we wouldn't want to give IL-6 blockers to a patient who might have sepsis. And whereas I think we can be very safe or sanguine about that with IL-1 blockers. It also, I think, obscures markers. In particular, CRP is a useful marker to figure out how the disease is going. And IL-6 will, of course, shut that down. So those are the reasons that I don't go to tocilizumab for MAS care. But there are places in the world where it's what's available, and so people have.
Yeah. Yeah, I think some of it is style and regional differences for sure. There are a couple of unique end organ complications of MAS that are extremely difficult to manage, and I wanted to give you a chance to tell us a little bit about them. So firstly, CNS involvement. How do you manage it, and what tips do you have?
So in primary HLH, CNS involvement is really common. It's up to half of patients. And some of them, it's such a driver that they actually need intrathecal chemotherapy. In our patients with rheumatic MAS, CNS findings of some kind are still common. Something like 30% of patients, something like 10 or 11% have seizures. As often the case with CNS manifestations, it's hard to tell how much is just being very sick, how much is hypertensive, how much is thrombosis from DIC, and how much is really primary macrophages in the CNS activated that are messing things up. So in general, we essentially never use intrathecal chemotherapy, and we just treat the MAS when these manifestations are going on. And so the question is, what do you treat with? I think we use the same general drugs. There is evidence that low-dose dexamethasone gets into the CNS better than lower doses of other kinds of steroids. There's no data that pulse steroids in the way we usually do it has any difficulty getting into the MAS, into the CNS. So, when we think about CNS, we often switch to dexamethasone, but I think the data for that are limited.
That's helpful. I feel like that is actually a struggle, a kind of bedside decision that you make with your heart and your mouth. So it's helpful to get your take on that. If you will, and I know this has some controversy around it, can you talk to us a little bit about the lung involvement? I know it's more common in children than adults, but what do you know about it, and what should we know about it?
Yeah, I think this is an incredibly important topic, and it's a very complicated issue. I really think it's one of the leading issues of controversy and of clinical importance in pediatric rheumatic disease, in particular in Still's disease management, where the use of cytokine blockers early has really changed the face of that disease, where a lot of half of those kids had chronic refractory arthritis, and now it's down to 10% or less. So it's the disease has transformed, but it's been transformed through biologics. So the question is whether biologics drive lung disease is a really important one. So if you'll give me a moment, I'll just outline a little bit the history of what's gone on here and how I think we should begin to think about it. And I'll tell you, this is very much my opinion. So we know that children with bad systemic JAA or bad Still's disease develop pulmonary issues that we never saw before. So 10, 15 years ago, there were case report levels of this kind of manifestation, and now it's reasonably common. So up to 5 or 7% of all patients. We have several that we manage here at Boston Children's Hospital. This increase in incidence of a very unusual disease, which can have pulmonary alveolar proteinosis, so alveolar space filling with surfactant-like debris, as well as pulmonary hypertension and lung inflammation. This new manifestation roughly coincides with the increased use of biologics, both IL-1 and IL-6, as early therapies in systemic JA patients. And so in almost all the patients in the US who have this lung complication have gotten biologics. So that obviously raises concerns. Many patients who have this lung disease react to some of these biological medicines with reactions that look very allergic. They may develop rashes or itching, eosinophilia, even anaphylaxis with tocilizumab infusion, which as an adult rheumatologist, which I also am, we never see that in our RA patients. Then there are risk factors, which include an HLA. There's the HLA class 2, HLA B115, that is strongly associated with risk. So maybe something suggesting an antigen presentation mechanism. Other risk factors are early age and a history of MAS. And so this idea, this complex of symptoms has led to the idea that the drug is causing it, that the patients getting the drug are reacting to the drug in a kind of reaction that has gotten the label DRESS, which is drug-related eosinophilia with systemic symptoms. And as you know, DRESS is an absolute contraindication to continuation of therapy because patients with DRESS, if you continue the drug, they get worse and worse, and it can be fatal. So that's the idea, and that's the origin, I think, of what people call the DRESS hypothesis of systemic JA lung disease. So my own thought is that we don't know what's going on, but I don't think the DRESS idea is correct. And I think that we have to be very careful here because the DRESS label and the general implication of therapy of these particular biologics can frighten physicians and patients into making incorrect decisions. So I have a couple of reasons why I think this is true. First, biologics nowadays are essentially ubiquitous, especially in severe stills. So there's inevitable confounding between disease features and treatment features that make an attribution of blame very difficult. And that's not just because all the patients that have severe disease have gotten biologics, because even in the patients who aren't that severe, when you use more biologics, you use less of other things. So if you think about the pre-biologic era, we were using steroids, we were using methotrexate, we were using leflunomide, we were using all sorts of TNF inhibitors, all sorts of drugs that we're not using in these patients. And so the fact that the pattern of treatment has changed doesn't tell you that it's the increase of treatment that makes a difference. It could tell you that the loss of certain things that we used to do might be the problem. Including, for example, we use a lot less steroids than we used to. A further problem, I think, is that this lung disease has been reported in patients who never received biologics. And we've seen that here at Boston Children's Hospital, too. And that's true in places like China, where a lot of the patients who've got this condition have never been on biologics. So it looks like there's some kind of temporal change going on that's independent of treatment, at least independent of these biologics.
Are you seeing an increase in adults as well, or is it really very much more common in children?
So we have seen it also in adult patients who've had very long-standing disease. It is very rare, and we don't know why that is. So we don't know whether there's a kind of a predilection having to do with the pediatric physiology. And we also know that if you look at the severity of Still's disease in general, the younger you are when you start probably means you have a higher genetic predisposition and the disease is worse. So MAS, for example, is much more common in kids who develop Still's disease before the age of 2 compared to kids who develop it at 15 or adults who develop it at 50. So the risk factors for this lung disease are much more common in children. That may be part of it.
Yeah, many unanswered questions. A lot more research is needed. I want to thank you for that excellent refresher on a very complicated disease. There is at the end of your manuscript a brilliant chart, which I think will be the fellow's friend for when you're rounding and seeing these patients and trying to kind of work through what to do. Peter, if it's okay, in the last couple minutes, I wanted to just talk a little bit about your career and learn a bit about kind of what drew you into rheumatology. You graduated from Amherst College with a degree in philosophy. And I have to ask you, you practice medicine throughout a global pandemic. You look after children and adults. What did you learn as an undergrad from the Stoics that you still use in your practice today?
That's a very interesting question. So, the Stoics believed that, when you look at what's the good for something, you look at what something is good for or good at. So, a good drink might be one that quenches your thirst. And they thought that therefore the good for humans was a virtue, not, for example, pleasure. And they thought that living virtuously was our main goal. I did enter philosophy, start philosophy thinking that it might help me to think about know how to live. But what I encountered instead was much more impressed by somebody like David Hume than by the Stoics. And David Hume defined what he called the is-ought problem, which is you can never get from what is to what ought to be. Even if, for example, you were believing in a higher being that had a wish of how you should behave, then the fact that that higher being wishes you to behave a certain way does not mean that you should, unless there's a previous guide that says you should do what the higher being says. So I actually, in the end, am not optimistic that philosophy will tell us how to live. What I think philosophy does, training does, is help us how to think clearly and to express ourselves clearly, in particular in writing, and to try to be unambiguous and direct. And I think that's mostly what I've tried to gain from my training.
That's useful advice all the same. I'm wondering, I'm always interested to know why people choose particular career paths. So what made you shift from philosophy to medicine, and particularly what drew you into both pediatric and adult rheumatology?
Yeah, I knew I wanted to do medicine since I was a kid. I entered college knowing that. I left college knowing that. I always thought philosophy was sort of a fun detour rather than a possible career choice. I liked science too, but I never thought I wanted to be an investigator. That mice never interested me, even as a medical student, which is very surprising. That since I know I've been running a mouse lab for for almost 15 years now, and I love it because of the way you can ask important questions. What drove me into med peds was actually very similar to what drove me into rheumatology. So there was a physician here named Dr. Jean Jackson, great clinician, adult trained, but also took care of pediatric rheumatology patients. And I shadowed her for a month when I was a third year medical student. And then I took a couple of years off, actually. And one of those years I spent mostly in Guatemala. And in Guatemala, I was working in the countryside and found that if you don't know how to take care of kids, you don't know how to take care of a lot of the world. And I've really loved the dual training. And I think it gives you an interesting perspective to see what's going on in kids and what's going on in adults. And I think really to see through what I think is a really pernicious mistake, which is the assumption that most things are different in children and adults. The kids are not little adults myth. That I think is mostly not true. They're much more like little adults than mice are, for example. And I think that most of the diseases that we have in pediatrics and adults are continuous syndromes. They're not individual diseases, and that we should learn from each other rather than assume that one is different from the other.
Yeah, that's good advice. And then do you have any advice for people who are considering trying to combine a pediatric and adult practice, or the kind of med peds pathway?
Yeah, I think it works fantastically well in rheumatology because I think most of the diseases are very similar. Most of all the therapies are used in both conditions. I think they're both really fun areas to practice in. And I think the transition population is interesting. So I think there are lots of good opportunities in the med-ped space.
Yeah. And your patients just keep getting older alongside you. So
but it's fun to see patients who are now 30-year-old attorneys getting married. And, I took the care of them when they were 3. It happened.
Amazing.
5. Yeah. Yeah.
So tell us a little bit about your basic and translational research group. What types of experiments are you doing, and how do you juggle both the clinical practice and your basic science research?
Yeah, I run a basic science lab. We work on 3 main areas: human genetics and what these mean for disease, especially focused on non-coding variants and genetic variability in diseases such as childhood lupus. We work on neutrophils and how they contribute to disease, and also how much heterogeneity there is and how does that happen, including a fascinating interaction between neutrophils and megakaryocytes called emperipolesis. And then we work on T cells, including a recent finding that T-resident memory cells are really important as one basis for why the same joints flare over and over again. So how do you juggle all of this? I don't know. My wife is a full-time academic physician. She publishes more papers than I do. When we were both early in our careers, we tended to talk of another 2-couple career, and they introduced the model of the gardener and the rose, that you can't be there needs to be a gardener and there needs to be a rose, and you can't be one or the other all the time. So we've been trying to alternate depending on where the need is since we've been married and since 1999. Although I have to confess that, especially since I took over as a division chief in 2021, she's been letting me be the rose more often.
So I feel like maybe that's the answer to my final question then, because it was going to be, what's your philosophy for a happy life in science and medicine? And perhaps that's it.
All right. Well, I'm omnivorous in my interests. I love medicine. I love science. I love history. I love philosophy. I take a lot of joy in people, my patients, my faculty, huge amount of joy in my trainees. I helped start Amigo, the pediatric rheumatology network in the ACR in 2010. And Karma, the adult version, was sort of a spin-off of that. And when I see those stickers around, it makes me very happy. I feel I'm pretty lucky in my wife and our 4 children. They're awesome. And I accept that I can't do everything perfectly all the time, but I find meaning in just about everything that I do. So even on days that I leave here late, and especially as division chief, that happens more than it doesn't happen, I usually leave very happy.
Well, that's just so good to hear. I want to thank you, Peter, for sharing your expertise, your experience with us today. That was a fantastic discussion, and it's just wonderful to hear how deeply you love your work and the people you look after and all the philosophies that drive you.
Vicky, thank you very much for inviting me.
My thanks today also goes to pediatricians and the rheumatologists who stretch and help children with rheumatic diseases live long and healthy lives. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media. Email us at podcast.rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.